Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist, professor, and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team, where we've worked across the state of Georgia, providing vaccination and testing to communities who do not have equitable access. I also lead Emory's COVID-19 videos, where we bring the latest information to you about COVID-19. Today, I am pleased to be joined by my friend and colleague, Dr. Carlos Del Rio, so that we can update you on the latest COVID-19 information. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory, and is the Executive Associate Dean of Emory University's School of Medicine at Grady Health System. Welcome, Dr. Del Rio, and thank you so much for joining me again today.
As always, happy to be with you.
Thank you. Quickly, let's look at where we are with COVID-19 across the United States. The virus continues to spread at a very fast pace nationwide, although that is actually hard to see given the lack of coverage that we've seen lately, with daily reports, however, always increasing for the past 14 days, increasing at least threefold since April. The US is averaging almost 96,000 COVID cases a day, which is up 57% from 2 weeks ago. Hospitalizations are also sharply up to almost 23,000 cases a day, a 26% jump in the past 2 weeks. Cases are rising in nearly every state, but the Northeast and the Midwest have been especially hard hit. In much of these regions, daily case reports are actually higher today than they were at the peak of last summer's Delta surge. The full impact of this surge is believed to be even greater than the numbers that we are seeing, given the incredible use of home testing that we're now seeing. Additionally, we've just recently hit a major milestone that is incredibly sad. The coronavirus has claimed more than 1 million lives in the United States since the start of the pandemic. This was once an unimaginable loss and an unimaginable number. More than 300 deaths are being announced each day on average, which is far fewer than we were seeing at the height of the Omicron surge several months ago, but we are still hitting this unbelievable milestone. So let's start there, Dr. Del Rio. On this incredibly somber note, do you remember back in April of 2020 when the IHME models projected we would hit maybe 250 to 500,000 deaths from COVID-19, and no one believed that that could possibly be true?
Oh, I certainly remember it. And again, if somebody had told me back then we're going to have 250,000 deaths or 500,000 deaths, I would have said there's absolutely no way. But I think this virus has shown us multiple things. And one of the things it has shown us about, again, I want to emphasize health inequities, right? Health inequities have been a driver of disease and mortality in this pandemic. Recent data I looked at yesterday showed that no matter what age group you looked at, the mortality has been higher among African Americans and Hispanics and Native Americans and Alaskan Native populations. So while, again, everybody has been impacted, the people that people that are in more vulnerable have been unequally impacted. So I think health equity, the degree of health inequality we have in our country, has been one of the drivers of the excess mortality. We have to also remember issues of access, issues of employment, issues of where you have to live, where you have to work, what do you have to do, your access to therapeutics, your access to vaccines, all that has played a role. In addition to that, I would say that the other driver of the mortality in our country, and we have to say it straight, has been misinformation. I don't think any of us predicted that in a pandemic we would have this amount. I mean, if you remember the movie Contagion, people were fighting each other to get a vaccine, right? There was fights to get a vaccine, but nobody has ever made a plan or a model in which there will be vaccine misinformation and people not wanting to be vaccinated. And recent data from the Kaiser Family Foundation suggests that about 300,000 of those deaths that we have seen in our country could have been prevented if people had been vaccinated. We have to remember that many of those deaths occurred after vaccines were readily available to everybody. So at the end of the day, all those things have contributed to the really high mortality in our country.
I want to go back to the data that you just shared from the Kaiser Family Foundation. 60% of the deaths just since June of 2021, when we had really robust access to vaccines in most places in the United States, but we had a wide variability of who was eligible from ages. 60% of those deaths are considered to have been avoidable. That is really awful to think about. And again, not ever been part of a movie that we've seen about a pandemic where we would talk about misinformation at the level that we've got going on here.
And not only misinformation, but actually, I would want to say that politicians who have actually spread misinformation, and opinion leaders who have actually spread misinformation. And I want to emphasize that the vaccines continue to be incredibly effective, and vaccines against respiratory viruses are not very good at being infected. But these vaccines remain incredibly effective in preventing you from getting critically ill and from dying from COVID. So when people say, what do I need to do if you have not been vaccinated, get vaccinated? And I want to conclude by saying, and in my book with Omicron, being fully vaccinated means being boosted. So if you have not been boosted, you need to get boosted.
So the latest data actually shows that about 78% of Americans have received at least one dose of the vaccine, and just 66%.
Yeah, but I want to emphasize that I don't know why we're tracking the one dose thing, because
Right.
one dose doesn't do anything for you. So we need to know how many are boosted. Other than that, at the end of the day, it really doesn't matter. I mean, getting one dose of vaccine really give you any protection whatsoever.
So do you think that hitting this milestone of 1 million deaths would be enough to move people from I've had one dose of the vaccine to getting it fully dosed or getting that booster?
One of the things that to me has been really a puzzle, and I don't understand, is how we're not simply outraged by the 1 million deaths. Even as you mentioned, 300 deaths per day. I mean, that is one, 747. That is one jumbo jet dropping from the skies every day. We had, when people died in the 9/11 tragedy, we had commissions, we had outrage, we had all sorts of things happen. We're not seeing that with people dying from COVID. And that to me is just incredibly painful. These are human lives, these are not just statistics. This our friends, it's our family members. So of many of us, I mean, if you look in, for example, an African American population, you know, basically 1 in 5 persons knows has died of COVID. We have to remember that this is really hitting home. And the other impact of this is actually, there's a report that I encourage people to read from the COVID Club that looks at the orphans from COVID. In our country, there are about 200,000 children under the age of 18 who have lost one or both caregivers as a result of COVID. That's going to have tremendous impact in the future of our country.
And those numbers are not equally distributed. As you said earlier when we were talking, 1 in 5 people in certain communities know someone who's been lost, and the 200,000 children in our country who've lost a primary caregiver to COVID-19, that is not equally distributed. And we need to remember that as well.
Absolutely. I mean, again, those of us who have access to masking, who have access to vaccines, who are privileged to be able to work from home, have a very different, risk than those that are working in meat packing plants, or those that are working in service industries, or those that are living in multi-generational households with only one bedroom where isolation is virtually impossible. So I mean, I was talking to a family yesterday. One of the teenagers living in the house got infected. It's a house that has 2 bedrooms and there's 3 generations living there in one bathroom. There's absolutely no way to isolate that person. So in other words, everybody in that household is going to get infected. And I think that is the reality that, unfortunately, we're not all equal in our risk of getting COVID in this country. And we need to understand that.
Yeah, that's exactly right. Another statistic that just came out is that while we have really lessened our masking suggestions, requirements, recommendations across the United States, there's new data to show that with this rapid growth that we're seeing, which again, we're not talking a lot about today, which is why we're here today to discuss it. 30% of us now live in a county, again, where masking would be recommended if you're indoors in a public space. 30%. That is going from, there's basically no required masking across the United States right now. Is that surprising to you that we've reached that level again?
Well, it's not surprising because two things have happened. Number one, the virus has evolved, and the virus is evolving faster than we've ever seen. Since the emergence of Omicron, we have seen this virus, evolve in so many ways. So we had, the original Omicron, BA1, it rapidly overtook Delta. And then we had the emergence of BA2, it rapidly overtook BA1. And now we have the emergence of, BA2.12.1. It's a variant, and each one of those is more transmissible, and each one of those provides more and more immune escape. So at the end of the day, when you have a more transmissible virus going around and more likely to be able to evade the immune system, you're going to start seeing more infections. And the reality is that, it's only a matter of time, I really think, when we will all become infected. Because, people say to me, I've been talking to a lot of people who've gotten infected in the last week, and people say to me, I've been doing the same thing I was doing before. Yes, but the virus is not doing the same thing. The virus has changed, and we have changed. We're more likely to go to restaurants. We're more likely to be in places we're not masked. And the reality is there's a lot of virus out there in the community. So you are going to get exposed and you are going to get infected. And if you're going to get infected, be absolutely sure that you're vaccinated and boosted. And then we can talk about testing, and we can talk about test and treat and other things we can do. In other words, we're also in a situation that we were not in 2020. And I want to emphasize that to people. What's happening today is not 2020. And every time we see these peaks in this virus, it's a different one. And it's not 2020 because we have vaccines, because we have testing, because we have therapeutics, and we have increasing levels of immunity in the population. We have to not forget that. We have more people immunized, more people with prior infection. So that alters the natural history of the disease, but you're still likely going to get infected. And I would tell you, if you get infected, it's not going to be mild. I mean, some people that I've talked to have been pretty miserable with symptoms.
Right. I've got several friends who've got it right now, and they are not very happy, but they are very aware of the fact that they're in better shape now than they would be if they had not been fully vaccinated. Let's move to hospitalizations really fast and talk about what this variant has meant for hospitalizations. While hospitalizations are indeed increasing in the United States, they are more modestly increasing than we've seen in some other surges. Is this because this variant is different in the way people need to be hospitalized, or is this really about the fact that enough of us have vaccinations?
I think it's more of the former, but I also think that it's because there's so much disease in the community, right? So in the past, people would get hospitalized with COVID. Now what happens is somebody, ended up at Grady with a gunshot wound, and they get tested and they have COVID because there's so much in the community. Now, at the hospital level, we still need to isolate that person. We still need to implement all the protocols because that person is infected and capable of transmitting to others. But the reality is many people are getting hospitalized right now with COVID, but not necessarily from COVID. So we're seeing less critical disease as a result of COVID in the ICU. Again, very different than 2020. 2020 would see these people coming in with, respiratory failure, multi-organ failure, ending up in the ICU. What we're seeing right now is a more mild disease, and we're seeing less people in the ICU, less people with critical disease. But, if I get infected with COVID and I have a stroke, it may be that I had a stroke as a result of COVID, but it may be that I had a stroke and I happen to have COVID. And when you get to the hospital and you get tested, you're going to be treated as if you had COVID, even though maybe the disease is not necessarily secondary to COVID.
Yeah, absolutely. And thank goodness we are not back where we were in 2020 with so many advances. Let's talk about one of those that just came out, boosters for kids. The FDA on Tuesday authorized a booster dose for the Pfizer COVID-19 vaccine for children ages 5 to 11. Children in this age group can get a booster shot if they are at least 5 months after they've received their primary 2-dose series, the FDA said. And it is important to note that this decision now goes to the CDC, which will be making a recommendation based on that after reviewing that. So that all is super good news, but let's put that into some context. Less than a third of the 28 million 5 to 11-year-old children in the United States have received 2 doses of COVID-19 vaccine, according to the data from the CDC. Why have we not seen an uptake of vaccination in this age group? And what will this booster mean when we don't already have good uptake?
Well, again, I don't think we've been very good at convincing parents that this vaccine make a big difference, right? And most kids that get COVID are not going to get critically ill and are going to do fine. So a lot of parents have said, well, I'd rather be like we used to do when I was a little kid with measles or other diseases, chickenpox, just get it and get over with, right? A lot of parents are in that category. Then you also have the data from the CDC saying that 75% of young kids have already gotten infected. So in a way, if your kid has been vaccinated and gotten infected, in a way, he's kind of been boosted. And then the third thing is, there's a lot of concern, particularly in young boys, about getting myocarditis. And I think there's a lot of risk benefit that many parents have to make that decision with their pediatrician and among themselves. And you have to decide, well, is it worth giving, my 15-year-old boy a booster or not because of the risk of myocarditis? And I think those are really difficult decisions. And it depends on how much virus there is in the circulation. It depends on how much what's happening. When we were, a couple of weeks ago, you may say, well, it's not really worth it. When we are today, you may say, yeah, it's really worth it. So it also, the decision-making process changes depending on what's happening in the community and what's happening with the virus.
Yeah, and we are definitely in a different place today than we were 2 weeks ago or even beginning of April. I was looking back at some notes from when you and I last did one of these videos. And at that time, I was saying cases have consistently gone down. And now we're saying exactly the opposite. Cases have gone up 61% in the past 2 weeks. But we
and I think that's a gross underestimation, because the reality is a lot of the people, I mean, all the people I've talked to in the last week, except for one, got diagnosed at home. Only one person went to a health department at a PCR test. So out of 12 people that I talked to, only one actually will appear in your numbers.
Yep. Yeah, exactly. Same for my friends as well. They were tested on an antigen test, other than one friend who was tested incidentally in the hospital. And like you said, needed to be in the hospital for something else, ended up having COVID, but did not know that they had it. Let's talk about boosters for not even just the 5 to 11-year-olds, but the previous recommendation for boosters for anyone in the United States who is over the age of 50 and fully vaccinated, or anyone with certain immunocompromising conditions, regardless of age. Is it still really important for us to get those boosters?
Well, again, I like to not call necessarily that a booster, but a fourth dose, right?
Okay.
The booster is a third dose, even though some people call it a booster. I like to think about it as a fourth dose. And I think the data that we've seen on fourth dose suggests that it does give an advantage as far as decrease the risk of severe disease and death for people over the age of 60. For people under the age of 60, it doesn't give that much of an advantage unless you're immunosuppressed. And therefore, I think if you're over the age of 60, absolutely. If you have more than 4 to 5 months from your third dose, go ahead and get a fourth dose. But if you're under the age of 60, I think you may say, well, I'm going to wait. I'm going to wait because in the fall there may be a new vaccine. There may be something different. So do you get it now? Do you wait until the fall? I think it's a very decision, and it's not a straightforward one. What we've seen in the data is the fourth dose does give you some protection against infection, but really goes away after 2 to 3 months. So the reality is, is it worth getting it right now? Well, maybe so. There's a lot of transmission. In 2 or 3 months, there may not be a lot of transmission. So you may get that, you may buy that additional protection against infection over the ensuing 2 to 3 weeks. The reality, though, is as a country, we cannot continue boosting each other, and the population every 4 to 6 months. I mean, we have to come up with a different strategy, but more importantly, we need better vaccines. We need different vaccines. These vaccines have gotten us over the hump, but I don't think that these vaccines are going to be the vaccine really get us to the finish line.
Let's talk about other kinds of vaccines for a moment. Yesterday was HIV Vaccine Awareness Day, which is a chance to do several things. First, to thank the volunteers, community members, health professionals, and scientists working together to find a safe and effective preventive HIV vaccine. It's also time to educate communities about the importance of preventive HIV vaccine research. So Dr. Del Rio, you've been very involved with HIV research here at Emory. Both of us spent our research work in the HIV arena prior to COVID. How might the vaccine advancements that we've seen since or during the COVID-19 pandemic translate to other diseases and infections like HIV?
Well, actually, I think it's the opposite way. It's all that research around developing an HIV vaccine that allowed us to have a COVID vaccine in record time. I mean, the work done on mRNA, the work done on adenovirus vectors was all being done because of HIV vaccine and because of the interest in developing an HIV vaccine. Do not forget that, Kissy Corbett and her team at the Vaccine Research Center were there working on HIV vaccine. So it's actually the investment of our government in developing an HIV vaccine, the establishment of infrastructure, like, for example, the HIV Clinical Trials Network. All those things actually allowed us to have a COVID vaccine. So, investment in one disease spilled into another one and actually allowed the progress in another one. Now, what we hope to see now is that what we learn in mRNA vaccines, for example, is going to translate into HIV vaccines. And in fact, Moderna has already started a clinical trial testing an mRNA vaccine against HIV. But developing an HIV vaccine has been really, I would say, an incredibly complex scientific challenge. And many times for many of us, also a very frustrating enterprise, right? Because we have done multiple trials, large trials, in which have not been able to show efficacy of an HIV vaccine. But we have had advances in prevention through treatment, through pre-exposure prophylaxis, in a variety of different interventions that have allowed people to decrease the risk of getting HIV. But I still think that we have to develop a vaccine. And I would say that, here at Emory, the Emory Vaccine Center is one of the world leading places in doing research around HIV vaccine.
Yes, that is indeed true. HIV has done a phenomenal job with treatments. Let's move to treatment now for COVID-19, where we've also seen some very big advances. One of the most significant recent changes of COVID-19 landscape is this wider availability of authorized outpatient treatments. So how well are some of these antiviral drugs working? And in a moment, we're going to walk through a couple of websites that we can get to show where they're available to you. But how well are they working?
Well, again, we have antiviral medications, and we also have monoclonal antibodies. The monoclonal antibody story has been a little more complicated because as the virus has mutated and changed, some of the monoclonals that used to be highly effective have lost efficacy, right? And we are no longer. I'll give you an example of sotrovimab. Sotrovimab was a great monoclonal against Omicron. It has very little activity today, and actually the FDA is no longer recommending it. And now we have bebtelovimab, and as a potential monoclonal antibody. But as far as oral pills, we have two. We have one called molnupiravir that actually was developed by researchers at Emory and Drug Discovery Center, and we also have a drug named Paxlovid or nitrinavir ritonavir, which is a drug that is available. And those are the two antivirals. Both drugs showed efficacy in decreasing the risk of severe disease, hospitalization, and death in people with COVID, outpatients with COVID. In other words, not with severe COVID. But both the drugs were tested in non-vaccinated high-risk populations. Nowadays, we're using them mostly in vaccinated, populations. And we really have no data of their efficacy in high-risk in vaccinated populations. So we really need to develop the database that says, okay, if you are 65 and you got COVID and you get COVID, does it matter? Does it make a difference? I mean, my does three things. Number one, it decreases the duration of your symptoms. Mm-hmm. So it improves your clinic. Number two, because it decreases the amount of virus, maybe it decreases transmission to other people. But number three, does taking antivirals decrease your risk of developing long COVID? Because all of us are still concerned about, if I get infected, could I develop long COVID? And those, to me, are three really important questions that we need to answer with the available antivirals. Having said that, if I were to get infected today, I would absolutely access, testing right away and access my care provider, get prescribed a COVID antiviral drug. Now, I would say the government has put something together called Test to Treat, a program to try to make this happen. And it's been, I would say, disappointing and frustrating that the system hasn't worked as it was supposed to work. And it hasn't worked for a variety of reasons. People don't get tested. They get tested too late because you have to start these drugs within 5 days of onset of symptoms. And if you wait 5 days to get tested, then you're not eligible anymore. You have to have a normal renal function, normal liver function. You have to, not be taking certain medications, or you may have a risk of having, complications. So a lot of primary care providers still are uncomfortable prescribing these drugs. And I think we need to do a lot of education in how to use these drugs effectively, because the reality is the government has made a significant investment. And the websites you're going to show, there's a lot of drug available right now in the drugstores, and we need to use them more effectively, especially right now when we're having a surge.
I think that that's also important. And, we have to emphasize how quickly you have to be able to get to these medications. So we're going to talk through two of these websites. I'm going to share my screen. So this first one is the government's Test to Treat website. And what you see on here as you get onto it is both a way to find where you can get tested, as well as a place to find treatment if you test positive. So you would go on here, you would hit this view locations, and then you would see some stuff come up in a moment, populating. If I put in my zip code, it will start to show me within 10 miles of where I live what I have available to me. And so you can scan out, you can get in closer, and it shows you a combination of places that you can go to get tested, as well as places that you could go to get treatment. So the blue circles are places that you can go that have antivirals available to treat COVID-19, and the diamonds are places that you can go to test that will help you get linked to treatment as quickly as possible. We wanted to show
and notice also there that you can actually, a lot of the available drugs is actually in CVS stores. And you can see, you can click on your CVS and you can rapidly book an appointment at the CVS to get tested and get treated right away, right?
Right. Yeah. So I just clicked on one of them, and you go right to their COVID-19 website that gives lots of resources. And from there, you can go all the way through. I wanted to show one other website that is available, and this is a slightly different way to look at this. This is the Office of Assistant Secretary for Preparedness and Response, showing a very, very similar thing, but again, in a slightly different way. This does not have testing sites available on it, but it does have locations and what kind of antivirals they have available at each of their websites. Each of their locations. And so you can look at the state of Georgia. Again, please note the distribution of availability. So we're going to get to a place where we need to talk about access and equality of access for these drugs as well. Atlanta has a preponderance of the locations in the state of Georgia, but then you can click on them and you can see what the store is that has it, a pharmacy, and which of the antivirals they have available to you at that store. So this particular Walmart that I pulled up has molnupiravir. It tells you it has 370 doses or courses of it available, and what time they last reported it, to give you an idea of how up to date this is for you to be able to find it. So,
and again, I want to emphasize to people what incredibly fortunate we are to have this right in our country. I mean, the great majority of people around the world do not have access to these medications, do not have access to drugs within 10 miles of where they live. So, and building this website and this information as a clinician is incredibly powerful for me to treat patients. So again, kudos to our government, to ASPR, and to others for developing these websites, because they truly are something really amazing for those of us who are interested in treating patients as soon as possible. Now, the other website I think we're showing, Jodie, is the website where you can actually order your test. Yesterday, Ron Klein, from the White House, said that because of the surge in cases, they're now allowing you to order a test free of charge, and they come to your home. In fact, I ordered mine yesterday. So I encourage people to have testing available at home, because if you get tested at home and you're found to be infected, you can then pretty much skip one step, right? You already got the test result. You can call your clinician and say, here's my test result, and get prescribed medications right away.
And I will just show that really quickly. So if you want to go on and order them, I did the last time they were available, and we strongly urge people to do it again. They just recently became available again. It's covid.gov, and if you put that into your computer, it will take you to this, and every address in the United States is available and eligible to order a COVID vaccine.
And it was yesterday that they now started the third round of free at-home testing.
Right. And so every single address can go in here and order tests to be sent to their home. And then you have them available. And then if you test positive, you can go to the other websites to look for antivirals if you are not doing well.
I mean, again, the challenge here, as you said, it's about equity, right? The challenge here is the people that don't have internet, that, can't access the system, that don't have, a primary care provider. And that to me is the biggest concern, is that the people that are probably most at need are the ones that have less access to this kind of resources. And we need to focus on health equity. We need to focus on getting the testing and the diagnosis and the treatments to the people that are most vulnerable and need it the most. And for that, we have to work harder. And I think the work that you and others have done really is transformative in that respect.
Thank you. It is incredibly important that we help each other, and that if you have a computer that works and you can help someone else find access to testing, to antivirals, to getting tests at home, that is the right thing to be doing. Dr. Del Rio, I think you and I are always so happy to be talking to each other and discussing the latest about COVID, but also it's unfortunate that we still are talking about increasing rates of COVID across the United States, particularly when we're pretty clear that they are going to be a vast underestimate. We've reached a remarkably awful milestone in this pandemic, and we all need to come together to make sure we don't lose more lives. And we do that by working to protect our communities with vaccinations, masking now, again, if you're in communities with high rates of transmission, making sure that we're all recognizing that we are in this together, and that every person's health in a transmissible infection depends on the people who are around them as well. So Dr. Del Rio, as always, thank you for your great advice and your insight as we digest more information. And for all of you watching, please stay safe.